Today's topic is one of significant interest to us as we transition from taking care of sick patients to trying to keep patients healthy. And we're very lucky to have a very distinguished visiting professor that Dr. Fuster will introduce in a little bit. And I'll just tell you our panel: Samir Bansalal, who's Assistant Professor of Medicine, Cardiology, Clinical Trials, and Global Health; Sandy Friedman, who's Clinician Extraordinaire, Associate Clinical Professor of Medicine; Larry Krakoff, Professor of Medicine, world-renowned hypertension expert; Oksana Moran, Professor of Medicine, Director of Interventional Cardiology Research and Clinical Trials; Don Smith, endocrinologist and cardiologist, Associate Professor of Medicine and Community Medicine; Raj Vitnathan, who's Assistant Professor, Department of Medicine and Population Health Science and Policy. Without further ado, one of our fellows, Brandon Kalenda, has put together a very, very interesting monograph on the subject, and will briefly summarize the topic for our panel.
Good evening. My name is Brandon Kalenda, one of the fellows in cardiology here. I'd like to begin by thanking Dr. Smith for joining us today. I'd also like to thank Dr. Fuster, Dr. Goldman. It's really their tireless efforts, their dedication that make nights like this one possible. So tonight's topic is an important one, as Dr. Goldman said, and it concerns primary prevention. And it's a topic that's directly relevant to the countless individuals worldwide who have never experienced a myocardial infarction or stroke. Cardiovascular disease, as you know, is a global epidemic, despite improvements recently in both prevention and treatment. In the United States, cardiovascular disease still accounts for nearly 1 in 3 deaths, exceeding both cancer and chronic lower respiratory disease, the number 2 and 3 causes of death combined. When we think about primary prevention, we seek not only prevention of the disease itself, but prevention of events: myocardial infarction, stroke, cardiovascular death. Primary prevention typically takes 2 forms. There's the population-based approach, which focuses efforts on large-scale reduction of common risk factors. This is akin to risk stratifying the entire population and intervening accordingly. Some examples would be New York City's bans on trans fats or smoking in restaurants. The second approach involves screening. This strategy strives to identify individuals at high risk for events in the near future and focusing preemptive treatments on this group. Tonight we'll be zooming in on this second approach: risk assessment in individual patients. To effectively risk stratify, we need tools to accurately quantify the patient's risk of future events so that we can engage in meaningful risk-benefit discussions with our patients. Then we can focus our most intensive treatment efforts on those for whom the risk of events is higher than the risk of treatment. Given that the risks of aspirin and statins are not trivial, this dividing line between high and low risk individuals is among the critical issues in primary prevention. We currently have a number of tools designed to assess the risk of individuals for major cardiovascular events. The recently developed Atherosclerotic Cardiovascular Disease, ASCVD, risk calculator was released in 2013 and is a means of quantifying risk based on simple, well-validated risk factors. It builds on the Framingham-based ATP3 calculator with key additions, including diabetes as a risk factor, stroke as a clinical endpoint, projection of both 10-year and lifetime event risk, and different scores for white and African American patients. However, the calculator and its associated guidelines have come under intense scrutiny since their release, in large part due to apparent overestimation of risk during internal and external validation. Things get very interesting in situations where the risk assessment is questionable, either in patients who seem to be at borderline risk or patients who really weren't represented in the calculator's derivation cohorts. Here, further testing can help our clinical judgment. In addition to the use of adjunct biomarkers like hsCRP, tools which assess the quantitative burden of ASCVD throughout the different vascular beds could be a powerful predictor of future MI or stroke. Atherosclerosis, after all, is a systemic disease, and it's something we can visualize both indirectly and directly. Low-dose CT, for example, can detect and quantify coronary calcifications, a surrogate marker of coronary plaque. There's ample data indicating that calcium score is a powerful prognostic tool regardless of Framingham risk score. Ankle brachial index is a useful tool to assess for peripheral vascular disease and also has predictive value for future coronary events. While less well validated, ultrasound can detect and quantify atherosclerotic plaque in the carotid and iliofemoral arteries and may offer enhanced ability to identify high-risk patients. Incorporating these tests together, we can quantify the extent and severity of systemic atherosclerosis with potential to identify high-risk patients better than clinical scoring systems alone. However, a number of questions remain. Can such a risk assessment be done in a safe, cost-effective, and time-efficient manner? Will the test results increase the likelihood that patients take their medications appropriately? In the meantime, as we work to identify these high-risk individuals, we cannot afford to overlook the population-wide burden of clinical risk factors and unhealthy behaviors. Our risk assessment tools will always be imperfect. Thus, public health measures with emphasis on population-wide behavioral and risk factor modification will be an absolutely essential component of preventing future cardiovascular events. Thank you.
Thanks very much, Brandon, for your work and excellent presentation on a subject that the way we like to approach it today is a futuristic way, and you will see in a moment how we are going to approach it. Anyway, let me introduce Dr. Sidney Smith. The last time he visited us, I think, was about 5 years ago, and obviously is recognized by all of you, and you choose him to come here as a visiting professor. Anyway, I will say that at the moment he's professor of medicine at the University of North Carolina at Chapel Hill. Going back, he obtained the MD degree at Yale Medical School, and then he went to the Brigham, where he had his internship in medicine, then his fellowship, and then eventually he moved into a staff position at the University of Colorado, where he was the assistant professor of medicine and director of the cardiovascular laboratory. It was in 1977 when he moved to San Diego. There he was clinical professor of medicine at the University of California at San Diego and director of the San Diego Cardiac Center. And was in 1994 where he became chief of the Division of Cardiology at the University of North Carolina, and presently, as we mentioned, is the professor of medicine at such university. He also goes back and forth. He goes to China, comes back, goes to China again, and there is honorary professor at Tangeshan Gangrene Hospital at Hebei Medical University in Shijiazhuang in Hebei, China. So having said this in terms of demographics or biography of Dr. Smith in terms of where he moves from where, I will now make a comment about his awards. He has a large number of local awards everywhere he has been. And then he has national awards, particularly from the American Heart Association, Physician of the Year, the National Center, Distinguished National Leadership Award, Gold Heart Award, Distinguished Achievement Award of the Council of Clinical Cardiology, the recently Ron Haddock International Impact Award, and then he also has award of a special recognition by the National Heart, Lung and Blood Institute. He occupied a number of positions. The most important ones, I would say, were President of the American Heart Association, President of the World Heart Federation, and then he has been involved with the American College of Cardiology as a number of committees, but particularly the chair of the ACC-AHA Prevention Guidelines Committee and then he has been also chairman of the committee on PTCA and others of the American College of Cardiology, and certainly of the task force on practical guidelines, which I think he served as a chairman 2006 and 2009. Well, then we have, he has been the chair of the new COCAT's preventive section, and in the editorial boards, he's part of 13 editorial boards, particularly American Journal of Cardiology, Journal of the American College of Cardiology, Circulation, and Nature Reviews Cardiology. So finally, not the least, he has been very instrumental in a number of aspects in the cardiovascular field. And going to his bibliography, his first paper in 1972 is Myocardial Blood Flow in Man. And he actually has a number of papers in physiology, then he moves into pathology, and finally, he's now in the preventive field. So he has been, I believe, very consistent in the movement that he has done from the very early stages. He has published close to 400 papers in very good peer-reviewed journals. Well, thank you very much for coming here, Sid. You certainly are a role model for everybody, for all of us. And I have to give you my congratulations for all the achievements. And certainly it's a pleasure to have you here today as the outstanding teaching wisdom and expertise, the Anandi Sharma, visiting professor, and Simon Dag Memorial Lecturer. You remember him well. Okay?
Honored to be here.
It's a pleasure.
Thank you.
Now you can sit in the middle. I never saw so many experts together. So Samir, Sandy Friedman, Larry Krakow, Roxana, Don Smith, Rajesh, and certainly Brandon. There are enough chairs here.
Dean, can you get this stopped? It's very annoying that this thing keeps going back and forth.
Well, I will complain. Just wait for a few questions to you.
See you in real rather than up here on the...
We'll get into you soon. Okay, from the back, if you can stop the movement.
That was excellent.
Yeah, okay. Well, first of all, the way I would like to approach this is the present of how these, all these aspects of assessment of cardiovascular disease and prevention are, and then I would like to approach the future, in which appears that entities like Google, IBM, Twitter, or Apple are going to be in charge. And it's quite fascinating how rapidly this is all moving. And so let's go into first into today. I'd like to ask you, Sid, the way I see things today and see what you can add. First of all, it seems that our approach is first we encounter a patient and we evaluate what is going on first clinically. Second, we have a number of tools and technologies that add to our encounter with the patient. And then I think we apply the so-called knowledge and intuition, and that is the clinical sense of what you do. And these are three critical aspects that I am dividing in three, because when we talk about IBM and Google and so forth, it's critical to know in which of these three aspects they are going to be involved with and what they are going to be adding, so the encounter with the patient. And the final issue is that then we have a pyramid of 4 different layers. Layer number 1 is acute disease, layer number on the top. Layer number 2 is stable, rather chronic disease perhaps. Layer number 3 is subclinical disease, and layer number 4 in the bottom is actually health. I think it's critical that the 3 aspects we are applying constantly to these 4 layers. And the only reason I'm presenting this is because all of our discussion is going to be focusing on the three aspects of how we approach the patient and in the four layers. And I'd like you to comment whether you think this is a fair approach to how we see the present approach to the patient by us as clinicians.
Well, thank you, Valentin. Maybe I would start by telling two stories, both of which have affected me in my relationship with patients. The first is in the cath lab, too many times at 2 o'clock or 3 o'clock in the morning, seeing the family of a patient that we've just, that's come in with a STEMI, and we've opened up the artery, and the question is, couldn't something have been done? Do we have to wait until they're lucky enough to survive a STEMI, or shouldn't we be getting there earlier? So one of the things that is driving me, based upon my experience in medicine, is the understanding that we need to get there earlier. We need to get to ischemic and atherosclerotic vascular disease in its preclinical form if we're going to make a difference. The second was an interview with the New York Times about 10 years ago, where they were concerned about a lot of online information to patients. And I was talking with a reporter from the New York Times whom I know well, and I said, well, you know, what's the problem with this? And she said, well, the physician's telling me that the patients are coming into their office with a lot of questions. And I said, frankly, it's the patient with no questions that bothers me. And that, I think, underlies the second point, and that is the need to educate the public and our patients about risk and about the risk factors. So those two things, getting there earlier and educating the public about risk factors, I think, are really the driving force behind my strategies and interest in prevention. And I think we're going to look at online methods of educating patients in terms of the latter, the educationalist, and I think that's going to be a huge asset. And I think that we need to look beyond the observational cohorts in terms of risk and try to understand when we can apply newer techniques, imaging, biomarkers that will allow us to identify subclinical disease, to hit the former issue of identifying subclinical disease and intervening sooner.
Okay, so we are going now to approach 5 different subjects on the present, and then will be one subject of the future. Now, the first subject of the present, I'd like to understand why something I believe is wrong. And I'd like to start with you, Larry. How is possible that hypertension, that is known today to be the #1 cause of mortality in the world, by far, is looked as something secondary to the statins, to the cholesterol, and so forth? Do you have an answer to that?
Well, thanks for the offer to display my ignorance. I don't have an answer to it because high blood pressure, first of all, requires measurement. It requires someone to be there to take the blood pressure, and in many parts of the world, it's not clear to me, is there someone there to do this? Second is linking that to an appropriate intervention, which means, I think for most of us would agree, the first step would be nutritional and lifestyle improvement. But looking at it from New York City, where people are actually thinner than they are in the middle of the country, how do you convince even an advanced, developed country to increase its walking, to decrease its fat intake, to do the very basic things that will undoubtedly reduce the blood pressure in populations by 5 millimeters or so, but account for a substantial reduction in events, and in other words, a major improvement, a major benefit. These, it seems to me, I can only speak to what I think might work in developed countries for a while, and I'm a great believer in telemetry. We home blood pressures for our
Yeah.
population.
Well,
for
we have
example.
to get thank you, because we have to be very brief, otherwise there's so much to cover today. Appreciate it. Rajesh, the curves, and you and I work on this, on hypertension is the number one, but not only in in underdeveloped countries, also in developed countries. So we have a problem. You're working on blood pressure in underdeveloped countries. But what is your view? Because it's across the world. You know there's lines in the top.
Thank you, Dr. Fuster. Yeah, absolutely correct that blood pressure is the leading risk factor for global mortality. It probably is underappreciated, and there are many probably sociological factors related to that. Awareness, treatment, and control rates are quite low throughout the world. Actually, some notable improvements in this country over the last decade or so, largely to efforts, actually, I believe, of organizations such as American Heart and American College in terms of get with the guidelines, et cetera. A lot of effort still needs to be put into low resource settings, not only in this country and other high-income countries, but in low and middle-income countries worldwide.
Thank you. Second problem, Don. Tell me why we all talk about 10-year risk factor profile when we like to live 70 years, 80 years, 90 years. It's not a joke. We have the data on 30 years. Why is not being used?
It should be used.
Yes, but it's not.
I certainly use it. It should be used. And if any of you are asking the question of what you should do and therefore what your patient should do, I think that is a very important thing. It goes from age 20 to age 59. And the question is how to interpret it. If you have a 30% risk in your lifetime of having a stroke or a heart attack, does that bother you? What if it goes to 50%? What if it goes to 70% generally, which is the highest risk? Would that make you do something? So by using that, the ASCVD calculator, you can get that for those age groups. And for me, I think it's very helpful for to tell other people, and it changes minds. So
Well,
I think it has to just be promoted.
Sid, you talk about 10-year follow-up, 7.5, 10%, but people don't talk about the 30-year follow-up in terms of risk factor profile, and I think this is is ridiculous.
No, I think you're right. Now, one of the things to make a point, though, is that previously we had no way of estimating the long-term 20, 30-year risk. We now have that in the new calculator. And so it should be used. I use it frequently. It's on my iPhone. You probably all have it on your iPhone. You can easily sit with a patient, go through it very quickly, and just take smoking and go from yes to no and show the patient the 10 or 15, 20% drop in risk. It's incredible how strong that can be in changing behavior. And I think you're absolutely right. We need to start talking about lifestyle and how that's influencing patients, and we now have it. It's now part of the new risk assessment, in addition to having stroke as well as heart disease. So I think we need to make a lot more out of long-term risk and the need to choose a healthy lifestyle.
Sandy, I have a question for you. Do you know at this moment, in terms of LDL cholesterol, there are 13 guidelines in the world?
No.
There are 13. So you don't think this is confusing? In other words, should someday...
Ignore them. It's not
Confusing?
confusing if you ignore them.
Just tell more about it.
Well, I beg your pardon?
Well, what I'm saying is that
I'm the clinician extraordinaire that he was talking about.
no, but should Sunday be able to pull all the guidelines together for the sake of the world? There are 13, and I will tell you there are differences from one to the
The
other.
problem is you say for the sake of the world. You see, I mean, I have my own little practice, So philosophically, my view is nobody's going to get a heart attack or stroke on my watch. That's my view. And when it does happen, it's devastating. So there's a difference between guidelines for populations and for underserviced parts of our population and what I'm going to do behind my desk. So in a certain way, as an educational tool, I understand Framingham and Reynolds may be very important, but it doesn't have any impact on me because people like me, we try to fix everything. And one of the amazing things is that as of maybe 10 or 15 years ago, I think that the tens of thousands of us in this business realized that their stroke and heart attack business just dried up. Even people with ischemic cardiomyopathies, they just stopped dying. And, it sounds like you're selling snake oil, but anybody in this business, you say, my God, you're still alive, and I'm just, and it's a fairly amazing thing. But I don't know if that answers.
But you are not saying, no, you say, but you are not saying we should get rid of the guidelines. What you're saying is you use your own judgment.
No,
I suspect it's a conflation of.
Things are more nuanced than the guidelines, much more nuanced. And they became more nuanced because you could take pictures of things and you can check particles and whatnot. And it's amazing how someone can sit in front of your desk and they can be just average to low risk, you think, until you take a picture, and all of a sudden they have the same risk of heart attack as if they'd had an MI in the past.
Yeah.
And it's a worldview of change about how you're going to handle that particular patient.
Okay, Sid, thank you very much. You are a doctor. Now, Sid, there is one issue that I think strikes me, okay. When you go over all the guidelines, they're very thick, by the way. Well, they're executive, shorter. But if you go to the NHLBI panel 3, 2001, 2002, that was actually very much focused on the strength of the treatment, the level of cholesterol, and so forth. And we all learned of that. And actually was good for the patient because he said, you have a goal. And that was very good. The present guidelines is more of the size. What should be the population that should be treated, that are not treated? And I think, in a way, it makes a lot of sense. What really makes me feel, and this is my question to you, there is should not approach adherence much more than all these 1,000 formulas, when in fact, you know the data, 30% of people take the statins that they should. The other 70% do not. And we spend time and hours in formulas and calculators and all of that, and we don't spend enough time into how in the world we can change behavior or make people to get into adherence. Should not be more fruitful?
Yeah, and in fact, I told the NIH when they asked me to chair this $22 million exercise, I would not do it unless they had 5 guidelines, that they had a 6 on implementation. I didn't want to do any more guidelines that sat on the shelf. And so there is a 6th guideline on the science, the evidence base for implementation on how to do this. And NIH has agreed to look at a variety of demonstration projects to show how they can be implemented. But if patients don't follow the recommendations, if the therapies don't get to the patient, it really is a waste of time and money. So I do think it's as important to spend money on understanding how we can get patients to change their behavior as it is to developing a new statin or a new ACE inhibitor. If you're going to look at how we're spending resources, I think you're absolutely right.
Well, final question that is of great concern, and this, maybe, Roxana, you can approach this. What is your view when you read the hypertension guidelines and you see a group that splits in the middle of the whole discussion, the JNC, 7 and 8, and then they set guidelines, and half of the people say, we don't agree in the panel, and they develop their own guidelines. Do you think this is, how do you view all of this from your perspective? Are your colleagues?
I find that, I'm honored to be on some of the guidelines just in a committee, and I can just tell you that when you put this whole thing together, it's not so simple. It's not so simple to come up with individual recommendation for the individual patient you're going to see on a Monday morning in your office. And I think it comes down to, even if you disagree with what you're reading and the general gestalt of what you're reading, it's what the evidence is and the recommendations that may or may not fit the specific patient population, but rather a large group based on the evidence. So I think at the end of the day, I look at guidelines, whether it's hypertension or on prevention and all of that, as a way to really guide me, but not give me specific recommendations for a specific patient. That's how I look at it.
Samir, how do you react?
No, I think that is.
Or you might say, I don't care. I understand it too.
I think in some ways I would put that and what Dr. Friedman said together, which is that I think most clinicians, and we rely on what is class 1, maybe till 2A, and then the rest of it is up to our opinion as well, just as it is for the panel. So I think disagreement in research or in the ivory tower of these guidelines, I think, is the nature of the beast. I don't think we should be surprised with that at all. But I think what is hardcore 1A level evidence, I think all of us can be easily married to that and practice most of that. But beyond 2A, I think it's any man's guess, and I think that's how it plays out anyways.
Okay. Brandon, do you think you're going to remember all of this stuff that you presented? That, let's say, when you read that, individuals with cardiovascular disease, high dose, individuals with primary elevation of LDL more than 190, maybe high dose if they tolerate it, individuals 40 to 75 years and diabetes, and LDL 70 to 189, 10 years, for the individuals. Do you think you're going to have a clue when you finish all this training program? You're going to be in the street, or you're going to use Sandy Friedman's approach?
So I think you point out an important idea here, which is that, as you said, there are a lot of guidelines, they're complicated, and there are a lot of guidelines for each particular problem. And I think if one can retain a sense of how to identify a patient as high risk and kind of really focus in on that and say, well, how high risk is this person? Is there potential that I'm underestimating or overestimating their risk? And then once you're zoomed in on that, then you can step back and maybe take your time and figure out what would be the class 1 indication here. But I think if one has the tools to simply identify someone as high risk, that's an important beginning.
Okay, Sid, I must say that the 2013 ACC-AHA that you were so involved, frankly, I think it makes sense in a way, at least the concept. You're trying to reach more people, those at a higher risk, and maybe all of us develop our own formula, which is not so precise as it is in the way it was written. Do you think that it is fair, the criticism of the risk calculator? Sure, there may be women were not enough in sensitivity, and maybe whites, and maybe too many elderly would get the statins that should not. But I frankly think that I don't think you can really criticize it in a way that is somewhat convincing. I think nothing is perfect, but you use 3 approaches. And it makes sense to me, but I'd like to know how you react to all the criticisms, editorials, and all of that.
No, I think in many instances, the criticism of the risk calculator is highly based in ignorance, and that is not understanding the intent of the risk calculator and how to use it. I mean, you can go back to some of the concerns about its estimation. The ones from Ridker and Cook were based on 3 cohorts that were actually considered to be used but were excluded. Why? Because in these observational cohorts, things like hypertension, for instance, rather than measuring blood pressure, they asked the patient, do you have a history of hypertension? So on the one hand, the cohorts that were used actually entered patients with known hypertension, so you know what's going on. And the 3 there, it's just, I think I have a history of hypertension. Check it. In those 3 cohorts, many of the patients during the period of time were started on statin therapy or revascularized. And so you come up with a situation where the estimation of risk was actually higher than what happened to them, and it turns out that they were taking statins. It's a proof of concept. If you take statins, you just heard, you take these therapies, we seem to see less events. So, some of the criticisms were thrown out by the NIH committee because the cohorts were not really appropriate to use. In other instances, the REGARD study and some of the other studies have actually shown that the risk calculator is reasonably good. Is it entirely accurate? No. It will, particularly in East Asians, South Asians, and in the Latin American population, it will not estimate accurately, and we need to fix, and we're looking at groups in China to do that. But it gets us into a ballpark. And that's where I have to come back and agree again that what really needs to occur is the discussion between the physician and the patient, using this evidence, but making a final decision based upon that discussion and the addition of other evidence. I think this is where the work with imaging, when you get into this area, is really important. And we've recommended coronary calcium, biomarkers, that there are other things, ABI, that can be added along with family history to help the physician and patient decide. So use it. I think it's simple to use, it's easy to use, it gets you into the ballpark, and if you're in an intermediate risk, particularly in an older patient where age can influence it, I think that's where we need to start talking about the issue of subclinical atherosclerosis and where imaging and other tests can be helpful.
See, there are, in my view, three positive things on the latest guidelines, and, because we have, at least there's a lot of effort that came out. One is actually the sharing of the patient and the physician, which is, I think, what Sandy Friedman was talking a little bit about it, and that is this is a shared kind of discussion. And I think the discussion with the patient can be more favorable than anything and to increase adherence. The other is the looking at the comorbid conditions. I think this is another one that I think is important. And the third one that it just came out is that these guidelines actually are much closer if you look at CT angiography as a model. You realize that these guidelines really touch into the people with the most burden of disease according to CT angiography, which is another positive thing. And just like whether you react also positively to aspects that I think are not necessarily the numbers and all of that we talk about, but it's the overall concept. I was asking actually, sorry.
You're asking me?
Yeah.
I sort of drifted off because I think that the guidelines are great. I think that the calculators they underestimate in people who are under 50.
No, I'm talking about the aspects that are added to the guidelines, which is comorbidity, the calcium burden of these, the sharing with the...
Yeah.
Sorry, call you Sid rather than Don.
Imaging has been the most important. And the coronary calcium score by far, to me, at least in this institution, trumps that. And I have put them out, and they're up here, so that you see what the scores are by age groups, 5 years, men and women. And these are one set, and these are the MESA sets that are used here. And they're very similar. But to be able to show after 5 years how the score increases without any treatment is extraordinarily important and gets the people in 20 years you're going to be equivalent to somebody who's had a heart attack. Does that bother you or not? These are the sort of definite statements you have to make people to make sure that they understand what you're talking about. To get a number, you have a score of 42. Ooh, what does that mean? I mean, it doesn't mean anything unless you can somehow, even if it's as a percentile, people don't even get that. So I think, to me, that's very important.
Samir, maybe Rajesh, since you guys are working a lot with adherence, to me it's quite striking the results from the NCDR Pinnacle Registry. You know, the NCDR is one of the most important registries in the country, certainly on a number of aspects, hypertension, cholesterol, and so forth. And they look at about 1 million patients who were statin eligible. And what is interesting, that only 32% would have been were treated following the 2013 ACC-AHA guidelines, which is what we talked about before. What I'm saying is that in the present time, if you use the guidelines of the ACC 2013, actually, according to the registry, only 32% of the patients are actually treated when 100% should be treated, saying that the adherence is absolutely terrible. So I'd like you to comment. And again, it's to emphasize a problem that we have, that really we have to overcome.
First of all, I just want to point out that an ex-Sinai fellow, Tom Maddox, has been on the board we've continued that good work on the other side of the country. But I think basically it comes down to the fact that we've shown this in multiple registries here in Europe and in Asia, The pure study has shown this, that really adherence to medication at discharge, the prescription rates are abysmal. The adherence beyond that, from the first refill on up to 2 years, further falls off. So if you actually extend that data from discharge out to 2 years, probably of those who are eligible, I would say maybe less than 10% are getting it. We've shown this also in the data that we merged between Freedom, Courage, and Barry, where in the setting of even a randomized trial, we could not get that up to more than 25 to 30%. So this is a huge issue, and I think the impact for these four therapies, which are our basic post-MI secondary prevention medications, we all know are in the order of about 70% risk reduction, but the implementation like severely lags. So
Dr. Kuster, can I just say
Sure.
something, though? I think, I wonder how much of this is because patients are not adherent, or how much of it is that physicians are reluctant to actually start some of these therapies in the patients for several reasons that's confounded and not collected in the registries. We know, for example, that the more potent dual antiplatelet agents are better for patients with acute coronary syndromes, yet if you look at the NCDR registry, in all acute coronary syndromes, the penetration of the use of prasugrel and ticagrelor in ACS is no more than 20% of the patient population. Is it because the physicians are reluctant for some reason to, or is this the adherence issue? And then the question comes back, is it that the calculator is not really giving the same feeling that the physician was having in wanting to treat the patient? Those pieces we'll never know. And I think that's the part that's very difficult when you look at these registries and try to understand why is that. Is it what you think it is, or is it multifactorial? And I think that's
But
something.
remember that the calculator is not being used if the patient has disease already, or if the LDL is very high. So the calculator is for certain groups of people.
No
So
question, no question.
No.
But I think that's something to think about as well when we're looking at these registries.
on the other hand, we have the issue of hypertension, Larry, which is quite fascinating. You know the discrepancy. Actually, you wrote a good editorial about this recently, and that is patients age 60 or over, rather than having a blood pressure less than 140 systolic, could be less than 150. This creates a complete disarray in the communities. But there's something that is coming out from the NCDR Pinnacle Registry, which I find fascinating, and that is those people that you are allowing blood pressure to be 150, these are people who now have developed more TIAs and strokes based on retrospective information. So what is your actually taking of this? Is this wrong then to go after age 60 to allow 150 systolic as being appropriate?
When this came out, I was, I'd say, sympathetic, using the wrong word probably, to the view that there was overtreatment. And I think it goes both ways. There's undertreatment, and based on the best trial data that the JNC8 could find, they chose the 150, which I thought was reasonable. Now that's trial data, but then there's the increasing experience, and what we're missing here is geriatrician, I must say, to deal with the overtreatment. And we might think in this country that's real. In others, it's probably far distant in the future. But overtreatment is a real issue, and so that we have to find the middle way, below 150, above some number. I'd leave it at that.
Yes, Sid.
Yeah, there is a corollary following the recommendation that everybody over the age of 60 should be under 150. That there's a second corollary recommendation we talked about at noon, that if they tolerate lowering the blood pressure to less than 140, that's fine. That's fine. So what I think the intent is, if you have somebody that is under 140, that's age 65 and passing out when they wake up in the morning, or if they are at 144, and on 4 antihypertensives, you don't need to send them to the cath lab for renal arteriograms to try to separate what we know definitely about control, and that those patients certainly that are not able to tolerate going less than 140 or at 145 may not have resistant hypertension. It's okay. So it's to get away from the Joint Commission coming around and looking at your charts and saying you don't have everybody under 140, you're not a good doctor. Maybe that the evidence strongly supports getting them under 150, and if they can tolerate it, the corollary, the expert recommendation, was under 140. So what they did was actually change all of the guidelines. Got rid of hypertension less than 130. Everything is 140 over 90 except for the older.
Okay, Rajesh.
Yeah, no, just to say, Dr. Fuster, I agree that we need to have, I think, a radical sort of deviation and disruption in the way we think about adherence. And we need to sort of move away from what really has not worked, as the data have shown, in terms of sort of individual interactions in the clinic, trying to educate, trying to show images, trying to show pictures. I think we really need to sort of radically rethink how, what the mechanism is behind actually getting people to do healthier things, whether it's taking tablets or physical activity. One of the things I've shared in this forum before was a fun example from Germany at a subway station where they recognized that 90% of the people were taking the escalator rather than the stairs. And what they decided to do was make the staircase a musical piano. And all of a sudden it became fun to climb the stairs because they could make song and make music. And after a few weeks of that, actually 75% of the people were taking the stairs rather than the escalator. So it's that sort of thing that I think we need to sort of radically rethink. How do we make things easier? How do we reduce the activation energy with respect to lifestyle modification, with respect to adherence, et cetera, and really sort of rethink how we're approaching it.
One issue that came from our trial in the polypill, which were 2,000 people, we studied adherence and the decrease of adherence, and actually there were a number of factors that were absolutely critical, and is actually in the context of the discussion that we are having at this present time. And one was pessimism, depression by having the disease. The other is feeling well, and why you take it. And the other is if you are young, and younger is the population, higher is the likelihood that they will stop taking the drugs. Quite interesting. And then there are issues of insurance and so forth. But the fact that you feel well, the fact that you feel to help with all of this, the depression state, and then the issues of the insurance and so forth are very important. So, but I guess we're getting now into the subject I want to discuss, Rajesh, which is a completely different approach that is being taking place. Is still, we are talking about the present time, and that is, this actually began in a paper by the American Heart Association, actually in 2010. And you remember then what came out is projecting what would happen in 2020 and trying for people to maintain health through behavior. And basically the approach is the opposite that we just had. Sandy, sorry, you had a question before I get into this. Sorry.
There's actually a theme running through all of this. And the theme is compliance, the theme is what is a normal blood pressure for an older person, et cetera. And all of these themes are related to the interaction of the patient to the doctor. And I read in the papers that the average interaction with a patient and doctor is 12.5 minutes. I'm convinced that people are, in a certain respect, very primitive, and they have to identify with their doctor. They have to really care for the doctor, and they have to really think that the doctor cares for them. And so all of the discussion doesn't go anywhere unless there's really that common denominator. And one of the examples is blood pressure. So Dr. Smith mentions the patient who's syncopized. Well, we all know that elderly people with stiff vessels, they come in with a variety of symptoms that may be related to low blood pressure. And, fatigue, I don't feel good. What's wrong? I don't know. I don't feel good. They drive you crazy. But the fact is, you got to sit there and listen to tether it out, to figure out what the normal blood pressure is for that particular person. And we live in an RVU environment. And until there's a philosophic change and a change that allows people to actually be doctors, you talk about the future, but we're talking about dinosaurs in the past.
Yeah, well,
we're looking to the past for solutions. I think
we'll talk. Actually, you're touching into something we'll talk in a moment, which is the big B, which is behavior, and I think has a lot to do with it. But I just like to get into the issue of what began to change. This was in 2010. You remember, Sid? there was a paper of how to establish national goals on health, and basically was to turn everything of risk factors into the other side. A healthy behavior means not to be obese, but rather to be thin, appropriate diet, not smoking, to have a healthy lifestyle in terms of exercise. And now recently has been added the other risk factors, which is like diabetes, hypertension, and high cholesterol because of the adherence, which is called also a problem of behavior. So the whole cardiovascular risk factor is now being converted into a behavior problem. And now I'd like to just present to you, see how you react. This came in 2010, and the American Heart Association said in 2020, there will be 20% reduce in mortality by following these good behavior patterns, okay? This is 2010. Well, I can tell you the data is just coming out from a different of sources, but one is the American Heart Association, and actually is that unfortunately, when now the data is being looked at what was achieved in the first 10 years, in fact, this 20% is only 6%. And that is that you can have any kind of feelings. Now they are talking about 25% by 2025. But the fact of the matter is how you achieve all of this. So the change in behavior as it was promoted in 2010 is a fantastic concept, but I will tell you, in the United States, only 2% of people at this time have none of the risk factors that we are mentioning. So 7 behavior proper. And in China, just the paper came out. I think you quote this in your presentation, Brandon. And in fact, it's only 0.2% of people in China, they have a healthy lifestyle. So Brandon, it seems I ignore you. Give us a sense of this concept. We are all projecting great things, but the reality is this is not happening.
You mean in terms of behavior?
Well, we're talking about what Sandy was really, we are dealing with a behavior problem here, where it goes into adherence and in many other things, rather than to all these formulas that we decide on guidelines and so forth, which are perfectly okay, but the fact of the matter is we face a problem here.
Absolutely. And I think that just underscores the fact that getting people to change behavior is one of the hardest things we can do. Even something that people know is toxic to them, like cigarette smoking, there are plenty of people who want to quit, are committed to change, and they can't do it. And I think it's a very difficult thing for the clinician to do. It requires a lot of trust if you're going to try and motivate someone to change, and then it requires a lot of follow-through when that motivated person needs continuous check-ins and so forth to keep them motivated. I think that's a great niche for community or group-based interventions where people can motivate each other, kind of say, well, you're right, I lost weight and I was doing this and you can do it too. And I think those group-based interventions that can serve as continual follow-up to the every 3 or 6 month physician visits could be every bit as important as that initial patient-doctor conversation.
Okay, Roxana, let's now try to see if there is a solution to this whole problem. What about imaging? I'm talking about, you have the paper that was published recently on 6,000 people on the HRP, which 3D ultrasound was used, and classification of the coronaries was used, and certainly you show the disease is diffuse. The disease starts at a young age. This is the study from Madrid, which is going to be published very soon too, 4,000 people. Is better than Framingham in an early stage of 3 years of follow-up, and this is understood. Framingham looks at a long term, and we talk about 30 years, but imaging tells you at a short term where there is a significant burden of disease. Could this change people? In other words, once you show people that really you have the disease, is not a joke. You didn't have an infarction, but you have that. Do you think this could be an approach?
I personally was incredibly surprised about the prevalence of subclinical atherosclerosis in this rather healthy population that had a very low event rate, actually. In the end, very low event rate. But even despite that, we were able to show that with multimodality imaging, you can actually find the level of people who have those higher events. And to me, it's an extremely convincing story to try to change behavior. But I can tell you that I am not sure we know how to change behavior, and perhaps what you're doing in your study to go to the generation before, the current generation, to try to influence the behavior of the older generation using the younger generation, might be a way to really look at this very, very differently. I think there's ample evidence now, and the bioimaging study also adds to this. I know you're going to do a continuation of this study with what you're doing in Spain and the continuation of the HRP study, but I wonder if what you're actually doing, which is the next step with your AHA study, is really the way to try to get behaviors to change. Because if there's anyone who could change my behavior, is perhaps my three young daughters, who constantly tell me, we need you to be around longer because you're an old mommy.
Yeah.
So
We'll talk in a moment. Samir, another issue is that we know imaging can detect disease, and really you can be, remember, if low number of events, but 3-year follow-up. When you project those events. Now, what about the microvasculature of the brain? What I'm saying is, should be beginning to convey to people that there is a problem here that can affect also cognitive function. And I'm not going into the details, but the data is overwhelming today.
Yeah, I would certainly agree on that. I think there are multiple implications of cardiovascular risk factors and the whole concept of primordial prevention. And one of those, I think, which may bring some additional attention to it, might be the link with cognitive dysfunction. I think there are multiple studies now looking at presence of cardiovascular risk factors, large vessel atherosclerosis, and then functional deficiency on a functional MRI, looking at cognitive dysfunction, and then incident dementia over the next 3 to 5 years. So I think I think tying back to your concept of lifetime risk, this is another outcome that needs to be added into that mix, is that cardiovascular risk factor management may have an impact on long-term cognitive function as well.
Okay, so I'd like to finish, the next 10, 15 minutes into where the future is, because it's becoming very clear. And it's becoming clear because the big companies who always look at the future are all absolutely aligned. I'm talking Google, IBM, Apple, Twitter. They're all aligned onto the same thing. And it's fascinating to see where this is going. Well, first of all, I'd like to summarize what we talk about. What we talk about is an instantaneous approach at a given time of somebody who presents to you, whether it's in the upper part of the pyramid, the middle, or the bottom, and then you act. And this is really the reality. And we said, and I did it specifically that for the following, you will see in a moment, that we as doctors, we have a patient contact, and that's where all this high behavior can be addressed. What is the problem with the patient? Is the patient going to be compliant? Then we have technologies and tools, and then we act according to knowledge, intuition, and so forth, into the diagnosis, management, prevention, and so forth. This is what we do today. Well, yeah, I don't know if you watched this last week, Charlie Rose with the CEO of IBM. What she was talking about is the same that the CEO of Google was talking 3 weeks before, and the CEO of Apple was talking 2 months ago. And it's fascinating to watch the three individuals saying exactly the same thing. And that is, we are going to help doctors. And the way they are going to help doctors is we have technology and tools. They will have much more data, much more. But to have a lot of data is going to be able to tell you what to do. And here comes IBM. IBM, what she did is to get an alliance with Apple. So Apple will provide the data, but IBM uses artificial intelligence. And to see how this data is going to help you to make the right decision, pulling all together based on validating data. That's what IBM is going to do. And that's the question. But, here's my... maybe, Sid, you can answer this. In a way, I see this is going to be very good as a new tool of data. I think instead of knowledge and intuition, what they are trying to tell you, leave your knowledge and intuition because we are going to tell you what to do based on all the information. But what really puzzles me, who's going to take care of the behavior? In other words, the understanding of that patient from another point of view. How are you going to address the adherence? What I'm saying is all these technologies are taking care of something, of two aspects, tools, and maybe knowledge and intuition will be more presented to you as a fact of how you should act, a little bit of guidelines. How do you think this is going to work?
I've been intrigued with these watches. Everybody's wearing 10,000 steps a day and getting reports back, and it seems like they're starting to get interested about a little more exercise and how they can do it. And it's not anything that's been started by NIH or guidelines or doctors. It's it's the internet. And I don't know what's motivating Google and these groups to get involved, but there's this societal interest in health and pooling of data that I think I see in favorable terms.
Well, this is part one. I will tell you into part two, which is the interesting one. Sandy?
Yeah, the wearable technology, the problem with it is that in absolute terms, the data really hasn't been validated for most of these gizmos, whether it's an Adidas shirt or a watch. The value of something that tells you how many steps you walk a day is not so much it can tell you how many calories you're burning, but the patient can use it as a guideline. And I have had patients who added an extra 400 steps a day, managed to lose 5 to 10 pounds, remarkably enough. The problem is, even if the data were validated, there's no, Apple started this, but there's no central place to put the data. In other words, this isn't like it goes to the physician's console in your electronic medical record and you push a button and you can see it will come. But right now, I mean, it's far away. And right now you have electronic medical records that can't talk to one another, so it's hard to imagine how you're going to take all of this stuff, get reproducible data, and then put it in a way that the physician can use to then interact with the patient. So those are the extra steps that have to be taken for this technology.
Yeah, but this is in cancer. Let me tell you one thing, Sandy. 5 years ago, everybody was critical, but there's one issue that this is working is cancer. In cancer, they are getting a lot of information, particularly on genetics, that really tells the doctor what to use. And you know, so what happens is with cardiovascular disease is more behavioral. It's not whether you have a cancer or you don't. It's a disease that starts at a young age and moves up. And actually, this is the issue that I want to discuss at the very end, because that to me is what is most attractive of these companies. And I'd like to comment about at least how some of us here sitting see the situation. And this is actually why we got the grant from the IHA to work at Harlem. And it's a continuity in which what you really look is not instantaneously, a lot of data, but you look from birth to aging in a line that changes constantly. And then what we do, well, that's the grant. We got into children aged 3 to 6, which we have very good data from Colombia, Spain, and so forth, into this is the time that behavior develops. And therefore, it's the opportunity that you have to really have an impact. This is what Roxana was talking about a minute ago. But we also work with the parents. And the parents are aged 20 to 30. The children that are about 1,000 are going to be followed until age 20. And the parents at 20 to 30 are going to be followed for 20 more years. So in fact, what we do with the parents is interesting. With the parents, we do something completely out of the box, which is to, like Alcohol Anonymous, groups of 10 that help each other. And then the issue of marketing, like you do in Kenya. You go into a risk factor and you get a culture, and everybody follows that risk factor that affects you. Well, what is interesting about the project is genetics is critical. It's the first time with Eric Schadt the genetics are approached with behavior. We take the saliva of the children and analyze the genetic interactions before you modify behavior and after. In the adults, we are going to follow the same thing. And that's the reason why these companies are interested in us. In fact, the fact that we got all this information is because we have a continuity, and what they want is to go on a line, which is not what we have done up until now, is a line that moves on in life, and it's like the pyramid. If the line is like this, the pyramid goes in parallel, so it's at the end of the line that you have the tip of the pyramid, which is the disease events, and in the bottom is the layer of health, which is closer to the early ages. And we are going to use imaging on that too, on these 20, 30-year-olds. These people have already disease. But I'd like to present this to you because these companies, I think, will be very, very helpful on this. It's really going, they can provide so much information. The only thing is the behavior, I think, will be a lot to learn from genetics. This is my view. I may be wrong. But I think it's going to be a lot to learn that how behavior is conditioning somehow from the genetic aspect, and you may condition the genetics with changes in behavior. I'd like you guys to comment on this because that to me is the future, is a longitudinal line. So, Rajesh?
Thank you, Dr. Fuster. I think it obviously has a lot of promise and potential. And I'm a believer and an advocate, and I think the potential for big data, whether it be used by individuals or whether it be used by groups or even at the sort of larger society level, also is very promising. I think that we have to also look, as I said, sort of carefully at ways to make choices either easier or to even make them non-choices. So, for example, if you look at smoking bans in restaurants and bars, we've essentially taken the choice away from people to smoke inside bars, and everyone is basically better off. And so I think that we can think about ways in which we can not necessarily regulate all aspects of life, but just think about ways in which we can target different types of approaches.
I agree with everything that Rajesh had to say. I think I also vehemently agree with you in terms of the tech companies getting involved. I think basically lifestyle change is, to me, in a very personal way, is a deeply psychiatric disease, really. And I think these companies really specialize in human behavior, and I think their help will be outstanding for us over the next 10 years to be able to hopefully make some real strides in this area.
Roxana?
Well, I always think of this when I go on Amazon.com. They know what things I like. They know what I buy. They show me and use that time to sell me new products that I actually have bought in the past or I might be interested in. And sometimes I know it wasn't me who was on that Amazon.com. It was my daughter because, teenage stuff comes on. But the truth is that the technology is out there and we need to figure out how to partner with these companies that have all this incredible data. And we work so hard in making case report forms and things like this, but actually the behavioral patterns in just shopping in and of itself shows you the power of what's out there and how we need to figure out how to utilize that to better the health of our patients. And I know it will come. You'll make it happen, Dr. Fuster.
See?
Yeah, I think I've heard that AHA and Google are talking, and I do think that feedback influences behavior. So I'd be positive on making some progress here. I think it's really the answer. Do you know if NIH is supporting any kind of research in this area? I mean, it's so important that I wonder where the research is it going to be industry basically that moves it along?
I think it's an economic issue here. This is beyond NIH. The budget that these people is huge budget. For example, in Google, I don't think I like to talk too much about it for obvious reasons because there are many things that are maybe private. But there's a lot of the economics of these are huge. I don't think NIH even for a minute can compete in doing this in the way these companies are presenting it.
It seems the private sector is moving it along, and it may well be that we'll see progress through that avenue.
See?
What I think should be looked at in terms of behavior, human behavior goes in sort of certain waves. And I think that that's the important thing to get the data on. For example, there was just data on the smoking with the nicotine cigarettes. In fact, the amount of smoking in teenagers has dropped almost 40% based on the fact that they're now using the nicotine inhalers because they can have all the different flavors and they can have all the different smoke-ending things. And so it's like an experiment. And if something like that can help, that would be major important. And so that sort of data will help that, I think. The other thing is when people start having children next. wow, then they start thinking, look, I've now got to think 50 years ahead. That's another important time. So to think at these important times as we go through life, and if we get into 60s and memory starts dropping a little bit, what is the things that are there that are important? So continuous data, but looking for these sort of places where people suddenly become interested in things that previously they weren't, I think might help a lot.
Larry? Well, I was delighted to hear about this study because the intersect of behavior and genetics has clearly, hopefully, developed a way of looking individually, what works for this type and that type. But there are studies in hypertension control using feedback, using internet strategies. There's one in Seattle, and there's a very interesting one in England, and it looks like they might work. In other words, that extending a Sandy's advice on a recurring basis to groups of people may well be very effective.
Sandy?
Well, you talked about the future in genes. I read a few really wild things in science. One of the 7 awards of the year in Science magazine was some Israelis who cured diabetics in rats. This has to do with a bionome by sterilizing their gut and feeding them the feces of other rats. And they're starting experiments like that in humans. So the whole concept of the bionome, I think, is kind of in sync with the kind of thing. The other thing that was in science was it turns out that there's a stage of sleep where cerebral spinal fluid goes into the brain, and it washes out beta amyloid. And there's research now into the quality of sleep, and there was yet other research, and I'll end with this, where cognition is impaired by sleep deprivation. I guess, and finally, I personally think that small vessel disease has to do with loss of impedance of large vessels and the velocity of blood flow going into the brain. So,
Yeah. Brandon, last word.
So I think one arena in which private industry can be really helpful is in helping individuals take ownership of their medical and health records. So not only would they have records of what kind of surgeries they had and medications they take or are supposed to be taking, but also that each individual could have a library of all their biometric data, right? Their weight, their activity level, their sleep levels and sleep quality over time. And perhaps that could be stored on a central server in Google Health or something like that. They could carry it around with them. They could access it on their phone. They could get feedback from it. And when they go to the doctor's office, that we could have easy access to it too. So maybe you could do some quick point of care analysis and see what are the big trends in this person's overall behavior.
Okay, we have 5 minutes. Questions or comments? Yes. Can you speak from the microphone now?
I think everybody would agree that the purpose of intervention with lifestyles or prophylactic medication is to prevent cardiovascular events. Hypertension or hyperlipidemia are not in and of themselves diseases, but they are major risk factors for the development of cardiovascular risks. And you said that hypertension was probably preeminent of all of the remediable risk factors that need to be approached. Now, there's been a lot of talk, both here and in the guidelines, about blood pressure targets. And that's a very controversial issue. But I think what has been missed in all of these discussions is that blood pressure versus risk are both continuous variables, not discontinuous. And there's nothing magical about the numbers 140 and 90. In fact, the evidence on which those numbers are based as a target is really extremely flimsy. We know that if you reduce blood pressure in all age groups from higher to lower, whether it's below 140 or not, you get an improvement in cardiovascular outcomes. And also, it's pretty obvious that if you have a blood pressure of 138 systolic, you're not immune to having any of those things happen to you. Conversely, if you have a blood pressure of 142, you're not going to have a stroke in the next few weeks. So it's an absurd to say that that is a hard and fast tipping point between health and disease. And I think most of the guidelines committee have failed to understand this. So the real question is, what do we tell the physicians about blood pressure targets? Clearly, 140/90 is a convenient shorthand method for indicating a goal. But I think that it should always be emphasized that the decision is that of the clinician based on his or her assessment of the clinical status of the patient, irrespective of age, and that a lower blood pressure may be appropriate. And by the way, lower blood pressures have been shown to be effective in preventing stroke and probably cognitive impairment. Or a lower blood pressure below 140 may not be appropriate for a particular patient, particularly if they develop symptoms at the lower blood pressure below 140/90. So I agree entirely with the sentiments that have been expressed that we need to individualize our approach to patients and not rely on guidelines as being infallible rules by which we have to operate in all circumstances.
Thank you. The only question that I have in this, I think you're absolutely correct, but are not figures helping you? Let me tell you, I used to see my patients and I was obsessed by having the pressure below 120. Okay? As the guidelines and the controversy has evolved, I accept a patient to have a blood pressure now 140, 145 if it is older. What I say is that we all work mechanically in a way, and there's always judgment, but I still think that to have figures help you in terms of managing, but I agree completely, this is a variable. The problem with blood pressure is that adherence is very low. As you know, how many people with hypertension are being treated? 30%. So this is a problem, and this is the issue that we are really trying to discuss here, how you change behavior. Or, yes.
The other thing we wanted to do with the guidelines was to look at home and ambulatory monitoring, and there wasn't enough money to do that. The group that AHA and ACC has together now is looking at that, and having some idea what's going on beyond what happens when the patient's in your office, I think can be very helpful in terms of treating patients.
Any other comment, question? Dr. Rosenson, do you have any comment?
I think it's very interesting. We take the different biomarkers, but we can't separate what's happening at the vessel wall. And a lot of these risk factors or risk markers interact in very complicated ways that may explain not only large vessel disease, but small vessel disease. So I think that we have to continue research with these surrogate markers and tie them to cardiovascular events to really move this field forward and decide whether 140/90 is good or bad for an individual. It may be on the milieu, their underlying lipids or fibrinogen, their hydration, the severity of the diabetes. So a lot more work to do to improve precision.
Well, maybe in that context we can finish by saying, the new priorities from NHLBI in research in the next 5 years. The first priority is the research in health at the molecular level, at the cellular level, at the behavioral level, and so forth. Number one priority, which is a huge change from the past, which the priority was disease. And I think this is a huge change. So the way you are talking about it, in fact, is part of the deal. And actually, I will tell you, the project that the AHA launched to people to participate, and we got the grant, was a project that had to have a basic component, a clinical component, and a social component, but was basically based on health. And that's how the Harlem Project evolved. So it's a huge change right now of using all the tools in the past, but going towards health. And I think it's part of what you're talking about. Okay, well, thank you very much to everybody, and certainly to all of you.